Hello everybody. Today we are going to discuss the questions on the nutrition which was asked in June 2022 DRNB critical care exam. And the question was nutritional risk assessment in the critically ill patient and the approach to nutrition in patient with the acute necrotizing pancreatitis. So general clinical assessment should be performed to assess malnutrition in the ICU until specific tool has been validated. The diagnosis of the malnutrition is suggested by the clinical observation and the complementary examination. Inflammation is associated with the high CRP and the lower. So the scores are subjective global assessment include the patient history and physical examination. Many nutritional assessment SF has a highest specificity and the nutritional risk score 2002 has highest sensitivity. So subjective global assessment was the gold standard. Muscle function may also be assessed by various tools such as hand grip dynamometer if the patient is conscious, being an especially good prognostic factor in conscious patient with acute respiratory distress syndrome. Bioelectrical impedance can be used to assess body composition and mainly lean body mass in stable patients not suffering from the fluid compartment shift. Several studies have described the advantage of bioimpedance in mainly phase angle in the evaluation of the prognosis of critically ill patient. However, its use is not a common practice. Recently, a CT scan has been used in ICU to assess lean body mass and may be promising tool for patient undergoing abdominal CT. A very recent study showed that a patient with low muscle mass found that admission have the higher length of stay and higher mortality. Non-specific ICU nutritional score has been validated thus so far. Existing nutritional screening tool NRS 2002 and malnutritional universal screening tool score have not been designed specifically for critically ill patients. Recently, the Nutrix score, which is a novel risk assessment tool, was proposed based on age, severity of the disease reflected by Apache, SOFA score, comorbidities, days from hospital to ICU admission, and including or not inflammation assessed by the level of intervention. So final composite of the Nutrix score was correlated with the mortality, and the expected advantage of the score was to be able to show interaction between the score and the nutritional intervention regarding outcome, hypothesizing that nutritional support might decrease the mortality in patient with the high Nutrix score. A limitation to this score is that no nutritional parameters are input. So let's have a look on the component of the Nutrix score. So the first component is age. If it is less than 50, then 0 points. If it is 50 to 75, 1 point. If more than 75, 2 points. Apache score less than 15, 0 point. 15 to 20, 1 point. 20 to 28, 2 point. More than 28, 3 point. SOFA score less than 6, 0 point. 6 to 10, 1 point. More than 10, 2 point. If number of comorbidities 0 to 1, 0 point. More than or equal to 2, 1 point. Days from hospital to the ICU admission 0 to less than 1, 1 point, more than 1, 0 point, more than or equal to 1, 1 point. Interleukin 6, 0 to less than 400, 0 point, more than or equal to 400, 1 point. Then Nutrix score system, if interleukin, if 6 to 10, the high risk, it is associated with the worst clinical outcome, mortality, ventilation, and these patients are most likely to benefit from the aggressive nutritional therapy. If it is a low score, these patients have the low malnutrition risk. The Nutrix scoring system, if no interleukin 6 is available. If it's a 5 to 9, then the high score, it is associated with the worst clinical outcome, and 0 to 4, it is a low score. So the NRS 2002 had a low risk of bias in two studies demonstrating malnutrition risk as an independent risk for greater hospital mortality. It appears that among all the screening tool, NRS 2002 and must have the strongest predictive value for mortality, and they are the easiest and quickest to calculate. Now let's discuss about the nutrition in the acute pancreatitis. So patient with the acute pancreatitis should be considered at moderate to high nutritional risk because of the catabolic nature of the disease and because of the impact of nutritional status of the disease development. So all patients with the predicted mild to moderate acute pancreatitis should be screened using validated screening methods such as nutritional risk screening 2002. However, the patient with the predicted severe acute pancreatitis should always be considered at a nutritional risk. Oral feeding shall be offered as soon as clinically tolerated and independent of serum lipase concentration in patient with the predicted mild acute pancreatitis. So low fat, soft oral diet shall be used when reinitiating oral feeding in patient with the mild acute pancreatitis. In patient with the acute pancreatitis and inability to feed orally, enteral nutrition shall be preferred to the parenteral nutrition. Enteral nutrition should be started early within 24 to 72 hours of admission in case of intolerance to the oral feed. In patients with the acute pancreatitis, a standard polymeric diet shall be used. If enteral nutrition is required in patients with acute pancreatitis, it should be administered via nasogastric tube. Administration via nasogastric tube should be preferred in cases of digestive intolerance such as pain and vomiting. Parenteral nutrition should be administered in patients with acute pancreatitis who do not tolerate enteral nutrition and who are unable to tolerate targeted nutritional requirement and if contraindication for enteral nutrition exist. When enteral nutrition is not feasible or contraindicated and parenteral nutrition is indicated, parenteral glutamine should be supplemented at 0.2 gram per kg per day of L-glutamine. Otherwise, there is no role of immunonutrition in severe acute pancreatitis. Probiotic cannot be recommended in patients with severe acute pancreatitis. Pancreatic enzyme should not be supplemented generally except in patients with obvious pancreatic exocrine insufficiency. Oral food intake in patients undergoing minimally invasive necrosectomy is safe and feasible and should be initiated in first 24 hours after the procedure if clinical state of pancreas a patient allows. In patients undergoing minimally invasive necrosectomy who are unable to be fed orally, enteral nutrition is indicated via nasojejunal as a preferred route. Parenteral nutrition is indicated in patients undergoing minimally invasive necrosectomy who do not tolerate enteral nutrition and who are unable to tolerate nutritional requirement or if there is exist contraindication for enteral nutrition. In patients with severe acute pancreatitis and intra-abdominal pressure 15 mmHg, early enteral nutrition should be initiated via nasojejunal as preferred route or nasogastric tube. Intra-abdominal pressure and the clinical condition of the patient during enteral nutrition shall be monitored continuously. In patients with the severe acute pancreatitis and intra-abdominal pressure of more than 15 mmHg, enteral nutrition should be initiated via nasovaginal route starting at 20 ml per hour, increasing the rate according to tolerance. Temporary reduction or discontinuation of the enteral nutrition should be considered when intra-abdominal pressure value further increase under enteral nutrition. In patients with the severe acute pancreatitis and intra-abdominal pressure of more than 20 mm or in presence of acute compartment syndrome, enteral nutrition should be stopped or parenteral nutrition should be initiated. In patients with the severe acute pancreatitis with open abdomen, enteral nutrition should be administered at least in a small amount. If required for the achievement of nutritional requirement, supplementary or total parenteral nutrition should be added. Now about chronic pancreatitis. Risk of malnutrition in chronic pancreatitis is high and malnutrition is common in patients with the chronic pancreatitis. So pancreatic insufficiency, abdominal pain, alcohol abuse, and the low food intake, diabetes mellitus, and smoking are main causes of malnutrition in pancreatitis. So nutritional status should be assessed according to symptoms, organic function, anthropometry, and biochemical value. Solely body mass index should not be used because it does not register sarcopenia in obese patients with chronic pancreatitis. Now, nutritional management in the pancreas. If the chronic pancreatitis, then the diagnostic evaluation includes Evaluation of nutritional status and screening for micro and macronutrient deficiency. Then we need to look for pancreatic exocrine insufficiency and pancreatic enzyme replacement therapy. Then we have to look for the diagnosis and management of the bone. And nutritional management includes oral nutrition or the oral nutrition supplementation, enteral and parenteral nutrition. Then about the evaluation of nutritional status and screening of micro and macronutrient deficiency. So first is anthropometric assessment, change in the body weight, functional assessment like hand grip and sit to stand test, 6-minute walk, skin fold thickness, waist and medium circumference, presence of ascites and edema. Then biochemical assessment, general assessment is sodium, potassium, chloride, liver test and kidney function, fat soluble vitamin like A, D, E, K, bone health like parathyroid hormone, calcium, trace elements like magnesium, selenium, zinc, and copper. Anemia screening like hemoglobin, iron studies, ferritin, vitamin B12, folate, and inflammatory markers like C-reactive protein, albumin upon pre-albumin ratio. Then symptom assessment is change in appetite and dietary intake, presence of symptom that impact on oral intake like nausea, pain, indigestion, and early satiety, presence of exocrine and endocrine dysfunction. Then about body composition, we need to assess like computed tomography, ultrasound imaging of the muscle stores, and DEXA scanning, that is bone mineral density. Patient should undergo screening for macro and the micronutrient deficiencies at least every 12 months, and screening may need to occur more frequently in those with the severe disease or uncontrolled malabsorption. When pancreatic exocrine insufficiency is diagnosed through clinical signs and symptoms, lab tests for malnutrition, malabsorption, and pancreatic enzyme replacement therapy shall be initiated. An accurate nutritional assessment is mandatory to detect signs of malnutrition. pH sensitive entry coated microsphere pancreatic enzyme replacement preparation shall be used for treating pancreatic exocrine insufficiency. Oral pancreatic enzyme should be distributed along the meal and snack. The posology aims at individual needs and depends on the severity of disease and composition of the meal. In practice, minimal lipase dose of 20,000 to 50,000 shall be taken together with the male meal and half that dose with the snack. Pancreatic enzyme should be supplemented in patient requiring enteral nutrition if signs of exocrine failure manifest. The efficacy of enzymatic pancreatic enzyme replacement therapy should be evaluated by the relief of gastrointestinal symptom and the improvement of nutritional parameters. In patients who do not respond, the evaluation should be extended to pancreatic function test. In case of unsatisfactory clinical response, pancreatic enzyme replacement therapy dosage should be increased or proton pump inhibitor should be added. If this method fails, the other causes of malabsorption, such as small intestinal bacterial overgrowth, should be excluded. Long-term pancreatic enzyme replacement therapy and nutritional status are similarly affected by all surgical procedures. Tissue preserving procedure shall be preferred. Patients with chronic pancreatitis, they are at risk of osteoporosis and and at high risk for osteopathy. So basic preventive measures should be advised in all patients with chronic pancreatitis, including adequate calcium, vitamin D intake, and if indicated, pancreatic enzyme supplementation, regular weight-bearing exercise, smoking and alcohol avoidance. Additional pharmacological treatment should be reserved for patients with osteopathy and in particular osteoporosis. Dual energy X-ray absorptiometry shall be used to identify patients with chronic pancreatitis osteopathy. Now about diagnosis and management of the bone disease. If there is increased risk of osteoporosis in chronic pancreatitis, then basic preventive measures should follow. If there is suspected osteoporosis is there, then we need to treat with calcium vitamin D supplementation, pancreatic enzyme replacement therapy, regular weight bearing exercise, and avoidance of alcohol and tobacco. If Then go for DEXA scan. If it is confirmed osteoporosis, then apply specific pharmacological treatment. In patients with the chronic pancreatitis who do not need to follow restrictive diet, chronic pancreatitis patient with normal nutritional status should be adhered to the well-balanced diet. In patient with the chronic pancreatitis, diet with the high fiber should be avoided. So, in patient with chronic pancreatitis, there is no need of dietary fat restriction unless symptom of steatoria cannot be controlled. Malnourished patient with chronic pancreatitis should be advised to consume high protein, high energy food in 5 to 6 small meals per day. Fat soluble and water soluble vitamin as well as minerals such as magnesium, iron, selenium, zinc should be monitored and administered if low concentrations are detected and if clinical signs of deficiency occur. Supplementation should be proposed to patients with known malabsorption. Oral nutritional supplements should be prescribed to undernourished patients only if oral nutrition is insufficient for reaching calorie and protein goals. If adequate enzyme supplementation and exclusion of bacterial overgrowth has not led to relief of malabsorption, its accompanying symptom, oral nutritional supplement with medium chain triglyceride can be administered. Enteral nutrition should be administered in patients with malnutrition who are not responding to the oral nutritional supplement. So enteral nutrition should be administered via nasojejunal route in patients with pain and delayed gastric emptying, persistent nausea, vomiting, and gastric outlet syndrome. Semi-elemental formula with medium chain triglyceride can be used if standard formula are not tolerated. Long-term jejunostomy access can be used in those requiring enteral nutrition for more than 30 days. Parenteral nutrition may be indicated in patients with gastric outlet obstruction and in those with complex fistula disease and in case of intolerance to enteral nutrition. For parenteral nutrition, the preferred route is central venous access. So, about oral nutritional management in chronic pancreatitis. If the patient is well-nourished patient without the deficiency, oral feeding with a non-restrictive well-balanced diet should follow. If malnourished patient, then oral feeding with the high protein, high energy food, 5 to 6 small meals per day should be given. Eventually, supplementation of the vitamin and trace element should be given. If oral nutrition is insufficient, then follow oral nutritional supplement. So, malnutrition patient with chronic pancreatitis, if in whom oral nutrition is insufficient, consider enteral nutrition if possible. But if signs of gastroparesis and gastric outlet is there, then go for enteral nutrition with the nasojejunal tube. If there are no signs of gastroparesis and gastric outlet obstruction, then go for enteral nutrition with the nasogastric. Start with the standard enteral nutritional formula. Consider semi-elemented formula if intolerance. Assess for clinical response and good tolerance. If your clinical response is good, then consider jejunostomy or percutaneous endoscopic gastrotomy with jejunal extension if long-term enteral nutrition is required, or alternative option is percutaneous endoscopic gastrotomy if long-term enteral nutrition is rare. If it is not possible, then go for parenteral. Thank you, Gal.